Welcome back. And today we're diving into something pretty startling, actually. It's a 2016 study. You might have heard of it, Macari and Daniel and the BMJ. They estimated medical error as the third leading cause of death in the U.S. We're talking upwards of, 251,000 deaths a year?
Yeah, it's a staggering figure. And it immediately throws up a red flag when you compare it to the official CDC numbers. The CDC lists accidents, unintentional injuries, as number 3. But their number is lower, around 222,000. So this study suggests iatrogenic harm from medical treatment itself is, statistically more deadly than things like car crashes.
Exactly, which is just massive, a huge public health issue that seems almost invisible in the official rankings. It doesn't show up alongside cancer or heart disease. So the mission for you listening in is to understand why. Why is this major finding sort of statistically hidden? What's going on with the official system?
Well, the crux of it lies in how we count deaths officially. The CDC relies entirely on the International Classification of Diseases system, the ICD codes. And historically, the ICD was designed to classify diseases, biological causes, the direct physical thing that led to death.
Right. So it's built for biology, not necessarily for process. And that structure, that's the snag, isn't it? The ICD system literally doesn't have a code for human error or system failure.
Precisely. There's no box to tick for that. So when a fatal error happens, maybe a delayed diagnosis or a mistake in surgery, the death certificate has to list a recognized biological cause, like sepsis or organ failure. It can't list the iatrogenic root cause, the system breakdown.
It captures the effect, but not the cause that triggered it all.
Exactly. And this isn't, a new problem. We've known about the system aspect for decades. Remember the 1999 Institute of Medicine report to Err is Human? That was pivotal.
Oh, yeah. That really kickstarted the modern patient safety movement.
It did. It estimated, 44,000 to 98,000 deaths back then, and crucially framed it as a system failure. Not about bad doctors, but about flawed processes, poor communication, fatigue, systems setting people up to fail.
And when you think about what counts as an error, it could be something not done, like forgetting a drug, an omission, or something done wrong, like the wrong dose, a commission.
Right. And medication errors alone are thought to be behind maybe half of the avoidable harm we see.
Which is huge. But then there's this other layer, this culture of silence you mentioned.
Yes, and it really compounds the problem. Estimates suggest less than 10% of errors actually get reported.
10%? Why so low?
Well, largely fear. Fear of lawsuits, fear of professional repercussions, the immense psychological distress for the clinicians involved. It creates this really damaging cycle. Fear leads to silence, and silence means institutions don't get the data they need to actually fix the underlying system problems.
Okay, so the system kind of protects itself by fostering silence. How do we break that? People talk about adopting a just culture. What does that actually involve? Sounds good, but is it practical?
It's a big shift. It requires real institutional commitment, building trust. A just culture focuses on safety over blame. It aims to differentiate between, human error, risky behavior, and actual negligence. The goal is to make it safe for staff to report errors and near misses without fear so everyone can learn.
So culture is key, but what about technology? Can that help enforce safety?
Absolutely necessary. Health informatics is critical here. Think about electronic health records, EHRs, or computerized physician order entry, CPOE. These aren't just about neat handwriting. They embed safety checks like flagging drug interactions or standardizing doses. They catch errors before they happen.
And could we use that same tech for better measurement too? Beyond just preventing errors.
That's the idea. Experts are pushing for EHRs to become learning systems. Systems that can capture and classify error data even near misses in real time. This would be separate from the ICD coding for death certificates, giving us much richer operational data to see what's really happening.
Data to actually validate estimates like Macadiri's, perhaps.
Exactly. And once you have that data, policy needs to catch up. We need bodies like the Centers for Medicare and Medicaid Services, CMS, to change how they pay, tying financial rewards or even penalties directly to measurable improvements in patient safety, in reducing preventable harm. That creates a powerful incentive.
Right. So it's not necessarily that errors are suddenly spiking. It's more that our main surveillance system, the ICD, just wasn't designed to see this specific type of cause iatrogenic harm. It makes us focus only on the final biological event. So for you listening, what does this actually mean?
It means we need to bridge that gap in how we understand causality in deaths. The Macari study actually had a specific recommendation: mandatory supplemental codes on death certificates. Codes just for preventable medical error, purely for tracking, separate from the biological ICD code.
Okay, which leads us to a final thought for you to chew on. Imagine if we did have two distinct national rankings for causes of death. One showing the biological causes, like heart disease, and another clearly showing system failures, like preventable medical error. How quickly do you think public health priorities and funding might shift to fix those known system flaws? Makes you think, doesn't it?